Hello everybody. Today we are going to discuss about the management of cardiogenic shock. So steps. So the actual management of the cardiogenic shock is always beginning in the emergency department. So prompt recognition of the cardiogenic shock by the emergency medical services personnel and emergency department provider is the key. So the following should make sure that in emergency department, the following steps that we need to be taken care of. So we should immediately obtain the early 12 lead ECG. Then, if the patient is hypotensive, then consider the administration of the vasopressor to achieve the minimal mean arterial pressure of more than 65 mmHg. If the patient is in respiratory distress, consider mechanical ventilation. Then, point of care ultra echocardiography to assess to look for the etiology and for the mechanical complication. And then we need to immediately transfer the patient for the primary PCI capable facilities. So this is the SCAI classification for the cardiogenic shock. According to this classification, we are categorizing the patient into five categories. That is A, at risk. That means patient is not hypotensive, not tachycardic, not hypoperfused, not in hypoperfusion, but still he is at risk of cardiogenic shock. Then the B beginning is the initial stage. That means the patient is hypotensive, tachycardic, but without signs of hypoperfusion. Then the C is classic. That means there is the onset of hypoperfusion signs, which require intervention like volume resuscitation, administration of the inotropes, vasopressor, mechanical support without deterioration after this treatment. Then the D is similar to category C, but it is getting worse with the failure of initial intervention. Then the E is refractory circulatory collapse. Frequently, the patient will go into the refractory cardiac arrest. So if the patient is in stage A and B, then patient can proceed directly to the cardiac catheterization lab. But if the patient is in C or D, that means if patient is hypoperfusion, if there are signs of hypoperfusion, then first we need to stabilize the patient before going for the further intervention. And if the patient is in category C, category E. So particularly those without ST segment elevation or who may have had prolonged out of hospital cardiac arrest, refractory ventricular arrhythmias, severe lactic acidosis with unfavorable prognosis. Then in this case, careful multidisciplinary team review of expected prognosis, then elucidation of prior patient wishes, goals of care is warranted, and then it is followed by the formal palliative care consultation. Now we'll see how to manage acute myocardial infarction related cardiogenic shock. The pathophysiologic premise of acute myocardial infarction related cardiogenic shock is an ischemic insult from an acute coronary thrombosis resulting in regional myocardial necrosis, impaired cardiac output due to concomitant systolic and diastolic dysfunction. So this leads to elevated intracardiac filling pressure and reflexive sympathetic activation, resulting in systemic vasoconstriction and high afterburn. So lastly, the patient with acute myocardial infarction may develop cardiogenic shock due to mechanical complications such as ventricular septal defects, papillary muscle rupture with consequent severe mitral regurgitation and free wall rupture. Now we'll see how to manage this. So if the cause of cardiogenic shock is related to acute myocardial infarction, then the following revascularization strategies is the solution to that. And for revascularization purpose, there are two strategies like primary coronary intervention and fibrinolysis. And the cornerstone of the treatment that improves the cardiogenic shock prognosis is emergent coronary revascularization techniques like PCI. But and about fibrinolysis is ineffective once the shock has set in due to reduced penetration into thrombus as there is decrease in blood pressure. So in this regard, fibrinolysis should be reserved in very selected patients for whom timely PCI is not possible. Thus, primary PCI is recommended as first-line therapy according to ESC guidelines. The optimal management of severe valvular disease is challenging in cardiogenic shock patients because of limited number of strengths. So several mechanisms that may contribute to the cardiogenic shock in setting of decompensated valvular disease. Initial stabilization is recommended before evaluation for corrective surgery. So cardiac surgery remains the gold standard treatment in the management of symptomatic valvular disease, but its invasiveness is associated with high mortality, leading to consider alternative therapies such as percutaneous management. The role of percutaneous interventional management of valvular heart disease is increasing in cardiogenic shock patients as more and more data reports its safety and good result in this severe population. However, it is important to remember that in case of valvular deterioration due to endocarditis, which is complicated by cardiogenic shock, surgery remains the cornerstone. And in decompensated severe aortic stenosis, current guidelines suggest urgent valvuloplasty as the bridge to transcatheter aortic valve replacement and surgical aortic valve replacement. So, management of aortic insufficiency may include atrial pacing to increase heart rate and shorten the diastolic dysfunction. So, this surgical aortic valve replacement is considered gold standard despite lack of data, but the transaortic valvular replacement should be considered in selected patients. In mitral regurgitation with the cardiogenic shock, surgery is indicated for primary mitral disease, but no evidence supports. Finally, severe mitral stenosis may be treated by percutaneous coronary valvuloplasty when surgery is not possible. So, in summary, the indication for cardiac surgery in case of cardiogenic shock due to valvular disease should be personalized. So, when medical treatment is the first line of choice, and it also seems important to reevaluate the interventional surgical indication according to the evolution of cardiogenic shock and to reconsider the indication before occurrence of refractory cardiogenic shock despite optimization of pharmacological treatment. So let's see what evidences are saying about this. So in 1999, the shock trial was published. And the conclusion of the shock trial was early revascularization resulted in the lower mortality from all causes at 6 months. The early revascularization is strongly considered for patients with acute myocardial infarction complicated by cardiogenic shock. Now, regarding multivessel coronary artery disease, so up to 80% of patients with acute myocardial infarction, cardiogenic shock will have multivessel coronary artery disease, and it is an independent predictor of the morbidity and mortality. So, despite the clinical precedence favoring coronary artery bypass grafting in patients with ischemic left ventricular dysfunction, less than 7% of shock patients undergo surgical revascularization, given their elevated risk for perioperative morbidity and mortality. So in 2019, Syntax trial was published, and the conclusion of this trial was CABG remains the standard of care for patients with three vessel or left main coronary artery disease since the use of CABG as compared with PCI resulted in lower rate of combined endpoint of major adverse cardiac and cerebrovascular event at 1 year. Now, in 2017, culprit trial was published. So, among patients who had multivessel coronary artery disease and acute myocardial infarction with cardiogenic shock, 30-day risk of composite of death and severe renal failure leading to renal replacement therapy was lower among those patients who initially underwent PCA of culprit lesion only than among those who underwent immediate multivessel PCA. But in 2019, the complete trial was published among patients with STEMI and multivessel coronary artery disease. So, according to this, the complete revascularization was superior to culprit lesion only PCI in reducing the risk of cardiovascular death, myocardial infarction, as well as the risk of cardiovascular death, myocardial infarction, and this ischemia related revascularization. So, regarding since we are discussing this acute myocardial infarction in in cardiogenic shock. So we have the look how to give this or we have the look what literature is saying about the antithrombotic therapy. So multiple factors pose a challenge to achieving prompt and safe and consistent antithrombotic effect in acute myocardial infarction cardiogenic shock. So it is because of the impaired absorption of oral P2Y12 inhibitor due to microcirculatory dysfunction and opioid-induced enteral dysmotility, platelet dysfunction due to hypothermia during targeted temperature control, microcirculatory thrombosis, myeloid dysfunction, and acute renal failure. Impaired cytochrome P450 dependent activation of clopidogrel due to hepatosplanchnic malperfusion and bleeding and vascular complication due to large bore access. So, given the high burden of hepatic and renal failure in cardiogenic shock, with associated risk for inconsistent pharmacokinetics and pharmacodynamics, the AHA position statement on cardiogenic shock and European guideline recommend the use of unfractionated heparin as anticoagulant of choice due to its rapid onset and reversibility. So, dual antiplatelet therapy with aspirin and oral P2Y12 inhibition is mainstay of contemporary antiplatelet therapy in patients with acute myocardial infarction. The newer generation P2Y12 inhibitors like prasugrel, ticagrelor in crushed formulation are generally the preferred oral agent because of their rapid onset of action and favorable pharmacodynamic compared to the clopidogrel. In circumstances where oral bioavailability may be limited, the use of intravenous P2Y12 inhibitor, canagliflozin, to bridge the gap in platelet inhibition may be warranted. With the ability to achieve steady-state concentration within 2 minutes of infusion and half-life of less than 6 minutes, canagliflozin have been studied in cardiac arrest patients and has been demonstrated to impart more consistent platelet inhibition without increased risk of bleeding compared to oral. So, dual antiplatelet therapy for shock patient with acute myocardial infarction trial, that is DAP shock AMI trial. It is the ongoing multicenter randomized study comparing primary clinical and lab endpoints of 30-day death in myocardial infarction and stroke and ADP-induced platelet aggregation between canagliflozin and ticagrelor in acute myocardial infarction cardiogenic shock patient. So there is limited data regarding clinical utility of glycoprotein 2B3A inhibitor in cardiogenic shock, which is related to a myocardial infarction, with concurrent class 2A recommendation in select non-cardiogenic shock patient with high thrombus burden, no reflow phenomenon, or abrupt periprocedural vessel closure. So we'll see now how to manage this heart failure related cardiogenic shock. So heart failure related cardiogenic shock has been recognized as the distinct etiology, which varies from this myocardial infarction related cardiogenic shock, not only in terms of pathophysiology and clinical presentation, but also with respect to the acute management and long-term prognosis. So when there is a ventricular function severely impaired, the chronic heart failure is progressed to the heart failure cardiogenic shock, resulting into the worsening hypoperfusion and subsequent acute or chronic hepatic and renal injury, lactic acidosis, reduced coronary perfusion, further activation of chemoreceptors and baroreceptors. So this factor creates the vicious cycle which worsens the cardiac function and body enters into the state of surge response, which leads to the multi-organ failure and death. So initial assessment should include identifying the etiology of heart failure and severity of cardiogenic shock according to SCAI stage definition and determining the hemodynamic congestive profile. Hence, early institution of PA catheter guided hemodynamic management may be useful in identifying worsening heart failure cardiogenic shock patients sooner and potentially lead to improved outcomes. So patient with the worsening hypotension and hypoperfusion with elevated lactate and evidence of end organ dysfunction should be transferred to dedicated cardiac ICU with invasive hemodynamic monitoring to reduce the risk of progression to the hemometabolic heart failure. So elevated feeling pressure have been recognized as a strong predictor of adverse outcome as opposed to cardiac output alone in advanced heart failure population patients. So, co-administration of the loop diuretics with thiazide and thiazide-like diuretic with acetazolamide can overcome this diuretic resistance via sequential nephron blockage and help to attain successful decongestion, that is UVOL. So in 2022, ADVOT trial was published. In this, the addition of acetazolamide to loop diuretic therapy in patients with acute decompensated heart failure resulted in greater incidence of successful decongestion. So, for patients experiencing clinical deterioration and failing to meet hemodynamic goal despite initial intervention, a selective and tailored approach to MCS device selection is recommended based on the severity of heart failure with goal of achieving hemodynamic unloading and restoring systemic perfusion. Now, the next concern is arrhythmia and conduction disorder management. So patients with cardiogenic shock have the high prevalence of arrhythmia and conduction disorder. So the reported incidence of atrial fibrillation is 20% and the episode of ventricular fibrillation is around 9 to 19%. So in addition, 4.5 to 21% patient may develop atrioventricular block and 4.5% may require pacemaker implantation during hospitalization. So there are no specific recommendation exist regarding supraventricular arrhythmia in cardiogenic shock. In patient with cardiogenic shock and arrhythmia, restoration of sinus rhythm, slowing heart rate if restoration fails, can be helpful to improve hemodynamic parameters. So, as for the choice of pharmacological treatment, amiodarone has demonstrated its efficacy for pharmacological cardioversion and seemed to be the drug of choice in critically ill patients. Now the paradigm of safe reduction within 48 hours without anticoagulation has been recently challenged because the recent data support there are always increased risk of thromboembolic event in atrial fibrillation beyond 12 hours of onset. And the risk is calculated by Chadwas. So, uh, if we are planning to cardiovert this atrial fibrillation patient whose onset is greater than 12 hours, or then we should be cautious while using cardioversion because there are if Chadwa score is high because there is always risk of the stroke. Finally, the electrical storm is a life-threatening condition characterized by the recurrent ventricular arrhythmia. The classic clinical definition of electrical storm is three or more sustained ventricular arrhythmia episodes separated by at least 5 minutes over 24 hours. So the management of rhythmic storm should always include cardiologists and must take several factors into account, namely the presence of underlying pro-arrhythmic cardiomyopathy, previously known as left ventricular function, the presence of implantable cardiovert defibrillator, and hemodynamic tolerance. Then, in addition, the search for myocardial ischemia substrate must be systematic. In cardiogenic shock patient, the immediate electrical cardioversion is always preferred if the patient is hemodynamically unstable. IV amiodarone is recommended as first-line antiarrhythmic therapy in electrical storm caused by structural heart disease in the absence of QT prolongation or torsionist pointers because of its greater efficacy for preventing recurrent ventricular tachycardia and suppressing ventricular tachycardia refractory to other antiarrhythmic therapy. The recommended dose is bolus of 300 mg over 20 minutes, then repeat 150 mg bolus over 10 minutes for recurrent ventricular arrhythmia, which is followed by the infusion of 1 mg per minute until free from ventricular arrhythmia for more than or equal to 6 hours, and then continue 0.5 mg per minute until electrical storm resolves. When amiodarone is ineffective as a monotherapy or for a higher risk presentation, lidocaine is often added as a second line therapy during further amiodarone loading. The initial bolus dose is 1 to 1.5 mg per kg. Of note, lidocaine is the more effective on ischemic myocardium, but can accumulate during decompensated heart failure or cardiogenic shock. Deep sedation and intubation is very effective treatment of electrical storm and is recommended in patients with intractable electrical storm refractory to drug. Therefore, implantable cardiovert defibrillator interrogation is crucial to check frequency, effectiveness, and appropriateness of the device therapy. Radiofrequency ablation as sympatholysis by stellar ganglion blockage or by definitive sympathectomy should be considered in patients with recurrent episode of ventricular arrhythmia, non-responsive to medical treatment or coronary vascularization. Finally, for eligible patients, we can consider heart transplantation and mechanical circulatory support. Now, regarding ICU management of cardiogenic shock, shock teams and regional system for the care of cardiogenic shock. The team-based intervention has been shown to expedite care and improve outcomes. Regarding vasopressors and inotropes, the acute management of patient with cardiogenic shock requires successful augmentation of cardiac output, typically with intravenous vasopressors and inotropes. These agents may enhance myocardial contractility by targeting the system of myocardial calcium fluxes, modulating adrenergic receptor, or through phosphodiesterase inhibition. Although the norepinephrine is often recommended as first-line agent of choice for treatment of cardiogenic shock, the data from clinical trial is limited. So these are the list of the inotropes and vasopressors that we are using for cardiogenic shock. So which is norepinephrine, the main effect is vasoconstriction. It is a first-line vasopressor in cardiogenic shock. And side effects are excessive. Sometimes it takes causing the excessive vasoconstriction and may result in arrhythmias. So next is dobutamine. It's mainly predominant action is on the beta 1 receptor. The main effect of this is inotropic and moderate vasodilation. It is the first line inotropic agent in cardiogenic shock, and the side effect is tachycardia and hypotension. Then the next agent is mendinone. Its main mechanism of action is phosphodiesterase inhibitor, and it acts as inotropic agent. It's a second line inotropic agent in cardiogenic shock. The side effects are tachyarrhythmia, hypotension, and headache. Then the last is levosimendan. It is a myofilament calcium sensitizer. The main effect is inotropy and inodilator. It is a second line inotropic agent in cardiogenic shock, and the side effects are hypotension, atrial ventricular tachyarrhythmia, and headache. Now, regarding the use of the vasopressors, we'll have a look on trials. So first is SOAP2 trial, which evaluated which compared between norepinephrine and dopamine. So they found there are the high rate of arrhythmias in cardiogenic shock subgroup and overall population with and and there was a high risk of mortality in dopamine group. Then the next is Optima study group, which compared norepinephrine to epinephrine, and it shows they reported the same hemodynamic efficacy with similar effect on arterial pressure and cardiac index, but epinephrine was associated with more arrhythmias, increased heart rate, and lactic acidosis. So an Optima study was stopped prematurely because of the increased incidence of refractory shock in cardiogenic shock patient receiving epinephrine. Then the next is the Doremi trial. Doremi trial, it is a randomized trial which compared mendrinone and dobutamine. So the primary composite outcome did not differ between mendrinone and dobutamine group, which include in-hospital death, resuscitated cardiac arrest, then non-fatal myocardial infarction, stroke. And the next is Survive study. Survive study included to 1,227 patients suffering from acute and chronic cardiogenic shock, and that was randomized to receive either intravenous levosimendan and intravenous dobutamine. And there was no difference was found in with regard to all-cause mortality at 180 days, but there was higher incidence of atrial fibrillation, hypokalemia, and headache in levosimendan group. Then regarding invasive hemodynamic monitoring, A growing body of evidence now support the routine early invasive hemodynamic assessment with PAC use for heart failure patient despite initial preliminary study failing to show benefit. So there are several potential theoretical advantages. So the timely, which include timely diagnosis of cardiogenic shock, including assessment of RV, LV congestive profiles, and elucidation of this PSI classification. Then optimal use of hemodynamically tailored mechanical circulatory device with serial follow-up assessment to inform decision making around the device de-escalation and de-escalation. Then correlation of cardiac performance with congestion to further inform the stratification of patient with cardiogenic shock and multi-organ systemic dysfunction. So there is emerging evidence suggesting the routine PSC use may be associated with improved survival in cardiogenic shock, particularly in patients who required the mechanical circulatory support device. And observational contemporary studies have demonstrated the reduction in ICU and hospital mortality in patients with acute myocardial infarction and heart failure across all size stages. So let's have a look on the trial. So with regard to the use of PAC catheter, there are two trials were published, that is ESCAPE trial and the PAC trial. So ESCAPE trial, now the conclusion of the ESCAPE trial was therapy to reduce volume overload during hospitalization for failure led to marked improvement in signs and symptoms of elevated pressure with or without PAC. And addition of PAC to careful assessment increased anticipated adverse event, but it did not affect the overall mortality. Now, regarding PAC's trial among patients with cardiogenic shock, the use of PAC was associated with lower in-hospital mortality, especially among those in SCI stages D and E. And patients who received the PAC were also more frequently rescued with temporary mechanical circulatory device or received advanced heart failure therapies. Now, temporary mechanical circulatory support devices are increasingly utilized in the management of cardiogenic shock worldwide. So we'll have a look on the few of this. As we know, the circulatory devices like intra-aortic balloon pump, Impella, tandem heart are using these devices we are using frequently. So let's have a look on the intra-aortic balloon pump. So IVP plays the crucial role in cardiac support by employing the principle of counterpulsation. These medical devices consist of a balloon-mounted catheter with the volume capacity ranging from 25 to 55 cc and it's strategically positioned in the descending aorta. The mechanism involves inflation during diastole, which enhances central aortic root diastolic pressure and coronary perfusion. During systole, the balloon deflates, create negative pressure zone, consequently reducing the LV after. This leads to the decreasing left ventricular cardiac work and myocardial oxygen consumption, with simultaneously augmenting cardiac output by up to 1 liter per minute. The clinical efficacy of IIPP has been explored through randomized control studies, most exclusively in case of myocardial infarction-related cardiogenic. Now, with regard to this, IIBP Shock 2 trial was published, which compared IIBP with other mechanical circulatory device like Impella, and it showed no significant difference in the mortality. So, notably, there is some evidence to suggest the presence of IIBP responders and non-responders. So, IIBP insertion had shown benefit in patients with non-ischemic cardiomyopathy and higher pulmonary artery pulsatility index score, indicating potential utility in appropriate patient selection for heart failure related cardiogenic shock. High SVR, low cardiac index at baseline diabetes mellitus patient have been shown to be the positive predictor of IVP response. The ongoing ADSHOC 2 trial aims to address this knowledge gap by prospectively comparing IVP to vasoactive therapy in heart failure cardiogenic shock patients with primary endpoint of 60-day survival and successful bridge to OHD. Now the next is percutaneous ventricular assist device. Impella, that is ventricular assist device, it is a catheter-based microaxial ventricular assist device that can deliver up to 5.5 liters of cardiac output by using principle of Archimedes screw, harnessing the impellar rotational kinetic energy to displace the blood from LV to aorta, thereby reducing LV preload oxygen consumption while increasing mean arterial pressure and tissue perfusion. So regarding this, the two trials were published. That is, first we'll have a look on the ISAR shock trial because it was published in 2008. So it showed the improved cardiac index with Impella, and overall 30-day mortality was similar in both Impella and IVP. Then IMPRESS trial was published in 2016, and the result of this trial indicate that outcome following mechanical circulatory support were similar with both Impella CP and IBP and patient with STEMI and cardiogenic shock undergoing primary PC. Now, this tandem heart is percutaneously placed via transeptal puncture for left-sided support, and it supports the right side as well. So tandem heart can be utilized in cases such as left ventricular thrombus and significant aortic regurgitation where transvalvular options are limited. So by splicing the oxygenator into circuit, it facilitated hemodynamic stabilization, perfusion, and decongestion with oxygenation analogously to VA. Given the transeptal approach, the placement of tandem heart is complicated in emergency setting and no mortality benefit has been proven for these devices. So let's have a look on the trials. Thiel et al. Published a trial in 2005 which compared tandem heart versus IBP. It showed improved cardiac index but more bleeding and similar 30-day mortality. Then Burkhoff et al. Published a trial in 2006 which compared tandem heart versus IBP, which showed improved cardiac hemodynamics, similar 30-day outcome, and adverse event rate. Then the next is extracorporeal membrane oxygenation. ECMO is commonly used as first-line mechanical circulatory support strategy in patients with acute, severe, and refractory cardiac and respiratory failure. The configuration of ECMO determines whether it is providing gas exchange or gas exchange with hemodynamic support. If ECMO is providing exclusively gas exchange, then it is VV ECMO, and if it is giving hemodynamically support so then it is VA. ECMO support can be inserted percutaneously via large bore venous cannula inserted in central vein, which drains the deoxygenated blood, cycles through external oxygenator and blood pump, and return the oxygenated blood to central artery via large bore arterial cannula. To prevent limb ischemia, the distal perfusion cannula is often used, usually placed through superficial femoral artery and sometimes through posterior tibial artery in retrograde fashion. The typical access site for VA ECMO cannulation include femoral and axillary artery and jugular and subclavian vein. Systemic anticoagulation is needed because of large cannula size, which exposes patient to the possibility of multiple complications. Overall, ECMO-associated morbidity and mortality are high. So there are few trials, that is ECLS shock trial, which is conducted by T. Hill and colleague on 417 patients with acute myocardial infarction complicated by cardiogenic shock, and there was no difference on death from any cause at 30 days. Moreover, the use of VA ECMO was associated with increased side effects, including bleeding. Then in 2023, Euroshock trial was published. Euroshock trial aimed to determine if early use of veno-arterial ECMO could improve outcome in patients with persistent cardiogenic shock following primary PCI. But due to limited number of patient recruitment, the trial had not come to any definitive conclusion. Then in 2023, ECMO cardiogenic shock trial was published, and extracorporeal life support is increasingly used in the treatment of infarct-related cardiogenic shock, despite the lack of evidence regarding its effect on mortality. So, in patient with acute myocardial infarction complicated by cardiogenic shock, with planned early revascularization, the risk of death from any cause at 30-day follow-up was not lower among patients who received ECLS therapy than among those who received medical therapy. Now, regarding management of respiratory failure, the incidence of acute respiratory failure in cardiogenic shock patient ranges between 50% to 88%, with more than 80% of the patient requiring respiratory support. So, cardiogenic pulmonary edema is caused because of the backward failure due to LV systolic and diastolic dysfunction. In addition, intrapleural pressure seems to be the major determinant of respiratory impairment. So during respiratory failure, active respiratory muscle contraction induces the negative pleural pressure, which increases venous return and the RV and LV pressure. Other factor which contribute to the further impairment in gas exchange. Indeed, the concurrent inflammatory response conduces to the development of alveolar edema by changing vascular membrane permeability, while AKI favors fluid retention. The compensatory increase in respiratory drive in response to hypoxia, hypercapnia, metabolic acidosis can further redirect cardiac output toward respiratory muscle, perpetuating myocardial ischemia and tissue hypoperfusion in cardiogenic shock patients. NIV represents the cornerstone in the management of cardiogenic pulmonary edema, but its place in cardiogenic shock management is more questionable, mainly due to hemodynamic instability and consciousness impairment. So there are two modalities of NIV that are used in practice, like CPAP and BiPAP. So minimal starting setting of positive pressure ventilation should be 5 to 10, and it should be adjusted according to the oxygen saturation. So although the CPAP is simpler technique, BiPAP could increase the tidal volume and seem to be preferable in patients with hypercapnia, chronic lung disease, and severe respiratory failure. And finally, the high flow nasal cannula shows the improvement in oxygenation, providing inconstant peak effect between 5 to 7. Where invasive mechanical ventilation is needed, patient with cardiogenic shock should benefit from early intubation. A recent study highlighted that each 1 hour delay in invasive mechanical ventilation initiation was associated with higher 30-day mortality. Now, regarding renal replacement therapy, acute kidney injury occurs in up to one half of the patient with cardiogenic shock, and 20% of these will require renal replacement therapy. So, AKI is the strong predictor of the poor outcome, regardless of etiology of cardiogenic shock. Indeed, patient with indication for RRT has twofold increase in the risk of in-hospital mortality, along the high risk of long-term dialysis when compared with those with no need for RRT. So, in recently published study, age, lactate, hemoglobin, pre-hospital, loop diuretic use, and baseline EGFR were identified as most important clinical predictor of poor outcome in patients with cardiogenic shock requiring RNT. So, the early initiation of high volume continuous venovenous hemofiltration resulted in improved outcome with lower in-hospital mortality and 30-day mortality rate when compared to patients undergoing low volume hemofiltration. Importantly, as patients with cardiogenic shock do not tolerate acute to fluid shift as observed in patients with intermittent hemodialysis. So the continuous RRT is the most commonly used strategy. So we'll see what is the recommendation of the ESC guideline. So recommendation one, immediate coronary angiography and PCI for infarct-related artery is recommended in patient with cardiogenic shock complicating acute coronary artery syndrome. It has a class of recommendation 1 and level of evidence B. Emergency CABG is recommended for ACS related cardiogenic shock if PCI of infarct related artery is not possible or unsuccessful. Again, it has a class of recommendation 1, level of evidence B. In case of hemodynamic instability, emergency surgical or catheter based repair of mechanical complication of ACS is recommended based on the heart team association. Class of recommendation 1, level of evidence C. Fibrinolysis should be considered in STEMI patient presenting with cardiogenic shock if PCI strategy is not available within 120 minutes from time of onset of STEMI diagnosis and mechanical complication have been ruled out. It has a class of recommendation 2A, level of evidence C. In patient with ACS and severe refractory cardiogenic shock, short-term mechanical circulatory device may be considered. Class of recommendation 2A, level 2B, level of evidence. The routine use of IBP in ACS patient with cardiogenic shock and without mechanical complication is not recommended. Class of recommendation 3, level of evidence B. So this is the schematic representation of management of the cardiogenic shock. So whenever the patient is presented in the emergency department with cardiogenic shock, we need to triage the patient based on the signs of hypoperfusion, and we need to divide that patient into two categories, that is hemodynamically stable patient and hemodynamically unstable patient. If if the patient is hemodynamically unstable, then we need to see whether the patient is in cardiogenic shock or low output heart failure. If the patient is in low output heart failure, then we shift the patient immediately to the ICU. And if the patient is in cardiogenic shock and the cause of the cardiogenic shock is related to acute coronary syndrome, then immediately shift the patient to the cath lab. Then the next thing that we need to assess is if the patient is hemodynamically stable, then we need to see the patient is in respiratory distress or not. If the patient is in respiratory distress, consider NIV and the early mechanical ventilation. If the patient is not in respiratory distress, then consider therapies like diuretics, vasodilator, and go for the clinical examinations to find out the underlying cause like X-ray, echo, ECG, ABG. Then reassess the patient after 60 to 90 minutes. Reassess on the basis of signs of hypoperfusion like blood pressure, heart rate, temperature, lactic acid level. If the patient is not improving, shift the patient to ICU. If improved, then we can admit this patient to ward, or we can take a call on the discharge. Thank you.